So a very good afternoon and welcome to this latest Knowlex webinar, and thanks very much to Applied Medical for making this possible. I'm Paul Anthony, I'm the conference producer here at Knowlex, where we disseminate healthcare information via our training modules, our conferences, social media, and of course, as you can see, via our webinars. Before we get the webinar underway, can I ask for some housekeeping rules? We ask that you don't share any of the presentation slides from today on social media, and please don't share any screen grabs of the presentation slides with anybody else. There will be a PDF version of the slides available to download after the webinar is finished, and we do have your emails, so we'll email you directly when the PDF version of the slides are available on the website. During the webinar, you'll be able to ask questions. All you've got to do is type them into the chat box. You'll find that on the right hand side of the screen, and we'll try and answer all your questions during the session. But if we don't manage to do that, then our speakers will answer them by email after the webinar has finished. Also, the session is being recorded. We understand that you've got jobs to do, so if for any reason you've got to leave before the end, you can watch it again at your leisure from Friday onwards. And please feel free to share the recorded version with your colleagues. So about the webinar, over the next hour, we're going to focus on, amongst other things, the PreciSSIon project, which employed an evidence-based care bundle to halve surgical site infection rates from 18% to 9.5% following elective colorectal surgery in 7 hospitals across the west of England. We're also going to cover the measurement strategies employed and provide tips for the success of that. So without further ado, let me introduce Anne Pulliblanc. She's clinical advisor for the PreciSSIon project. And we're also joined by Leslie Jordan, who amongst other job titles is the consultant anaesthetist and associate chief medical officer patient safety and quality improvement at Royal United Hospitals in Bath. So Anne, welcome. Perhaps you could get the session underway.
Yeah, thanks, Paul. So while Leslie shares the slides, we are going to present to you PreciSSIon 1 and PreciSSIon 2. And it's a tale of two halves, really. We're going to present to you a fantastic success, followed by our current challenges. So I'm Anne Pulliblanc, and I'm a colorectal surgeon in North Bristol.
And I'm Leslie Jordan, as Paul said, from the RUH, but I'm also a clinical lead for the Health Innovation West of England. And in that role, I'm currently leading our PreciSSIon project.
Yeah, so I feel a bit like the artist formerly known as Prince. I was previously the medical director of the Health Innovation Network, which is now formerly known as the AHSN. There are the AHSNs, there are 15 of us in England. And the aim of the HINs, as they are now known, is to improve healthcare at pace and scale across the region. And the reason we're showing you this is that we needed the support of the HIN, or the HSN as it was, to deliver these region-wide projects. And our patch is down in the west. You can see us there, and we cover a population of about 2.5 million people. Now, we all know that surgical site infection is an infection in a surgical wound. It can cause pain and discomfort for patients. Treatment increases antimicrobial use. It can increase length of stay and have a long-term impact on quality of life, as it also increases the risk of an incisional hernia. And at its most severe, it can cause a return to theatre. It costs the NHS about £980 million a year, and is particularly high after bowel surgery or colorectal surgery, because we have bowel organisms in the operative field. But despite that, most colorectal surgeons do not know their surgical site infection rates, as they're not included in the mandatory reporting. So the PreciSSIon journey started at North Bristol, when back in 2010, yes, I have been doing it this long, that we tried to measure surgical site infection. And I tried various ways using different people and colorectal nurses, enhanced recovery nurses, telephone only, telephone and paper. And then we implemented a 4-point care bundle and managed to halve surgical site infection from 20% to 10%, which has been sustained ever since. Now, when you see the care bundle, it might look a bit old-fashioned, and that's because I chose the most evidence-based things back in 2013. And so the PreciSSIon Collaborative was born, which is a collaborative to adopt and spread that work to the 7 hospitals in the west of England, and it stands for Preventing Surgical Site Infection across a region. So the 7 hospitals are shown here. They actually became 5 trusts during the project, and it started in 2019 and ran till March 2021. So the aim of the project was firstly to reliably measure SSI rates following elective colorectal surgery, as no one was really doing that, and then to implement the evidence-based bundle of care that we had already implemented at North Bristol. And we had an aim to reduce surgical site infection by 50% because that is what we had previously achieved. Now, the bundle was 2% chlorhexidine prep, the use of antibacterial sutures for muscle and skin, a second dose of antibiotics after 4 hours, and use of a dual ring wound protector. And I think the 2% chlorhexidine may seem like standard of care now, but even in 2019, some of our surgeons were still using betadine to prep. So our baseline SSI rate was 18%, and you can see there was a huge range there. And that's about where we started at North Bristol. It's a fact that the more you look for surgical site infection, the more that you'll find. You'll be aware that in the WHO checklist, several of the questions relate to SSI, and it was very important that we made sure people were compliant with this greater than 90% before we started adding in other bundle elements. So the elements in the WHO bundle are on-time antibiotics, maintaining normothermia, clipping wounds, not shaving, and reliable glucose control in diabetics. So all hospitals checked that they were doing the basics right before we started on this project. Many of you will be familiar with the Public Health England Surgical Wound Healing Questionnaire, which is a validated questionnaire which we use in this country to measure SSI. Patients are asked a lot of questions that you can see there, and depending on their answers, an SSI is diagnosed if they fit criteria 1, 2, or 3. And I'm just going to bring your attention to, could you just go back a minute, Leslie? I'm just going to bring your attention to criteria 1 and criteria 3, because it says that antibiotics have been prescribed. And when we've looked at over 1,000 patients at MBT, although this is patient-reported SSI, in fact, 93% of them had antibiotics prescribed. So although we call it patient-reported, actually 93% of patients have seen a clinician who's made a diagnosis. Next slide. And why do we use patient-reported data? Well, if you just use in-hospital SSI and readmissions, you only get the tip of the iceberg, because 67% of surgical site infections after elective colorectal surgery present in the community, and our median length of stay is only 5 days. So this just illustrates that when we looked at almost 1,300 patients who'd responded to our questionnaire, as I've just said, most presented in the community, and only 21% had symptoms by day 5, which is their average length of stay. And most presented between 11 and 15 days. So in order to do this project, we needed huge collaboration across teams and across the patient journey. SSI was measured by various people in different hospitals depending on what was available to them. Some hospitals had the luxury of an SSI nurse, others used colorectal specialists or enhanced recovery nurses. We also got executive sponsorship to try and highlight the importance of this project within trusts. And then in theatre, we needed the collaboration of surgeons, theatre nurses, ODPs, anaesthetists to make this happen. We had one face-to-face meeting in 2019, and then this happened, COVID. So this was the first time we've ever delivered a project remotely, and after our first meeting, all our subsequent meetings were held online. As you can see, it was Christmas. So if you say you're going to do something, it's really important that you do what you say you do and that you need to measure that it's happening. So we measured compliance with the bundle, and this is where the theatre teams came in. And you can see on the left is an example of a data collection sheet where we recorded that the bundle was being delivered for every patient. And this is where the theatre nurses came in. Most hospitals did this on paper. A couple of hospitals did make this electronic and integrated it with their existing theatre systems. On the right is a video that we made for theatre nurses to try and show them how important their role was in this project. So the quality improvement processes were really important. And I have to say, surgeons, I'm allowed to say this because I am one, surgeons are not very au fait with quality improvement. We are very research based. And so it's really important that all of our teams were taught the principles of quality improvement. So first of all, we had a reliable outcome measure, which is SSI measurement at 30 days. And our process measures were compliance with the bundle. And that's to ensure that the work is as it's really done, not work as we imagine it. Once we had lots of data, teams were able to feed back individual surgeons' own data. And this can be useful for surgeons who might not have wanted to participate in the project, as it can be quite useful to show someone if their rates are higher than others. And owning the data is really important so that the team feel part of this, and feeding back the data at regular intervals means that all members of the team know that their work is of importance. The theatre teams were also crucial. I've mentioned scrub nurses measuring compliance, but also they prompted people to do the right thing by, for example, only offering antibacterial sutures. And ODPs and anaesthetists also got involved by prompting us for the 4-hour repeat antibiotics. It was important that we had executive sponsorship for this because it means that if teams are struggling to unblock things, that there is someone there that they can turn to. The regional collaborative was also really important for teams to learn from each other, support each other, and also it was really good to have that camaraderie during the COVID pandemic. So all trusts successfully measured SSI, and all trusts implemented the bundle. The compliance with the bundle is shown below. You will note that the wound protector is has the lowest compliance, and that is because sometimes you just can't use a wound protector as a surgeon. If a patient has adhesions, it's just not possible. So we achieved an 80% average response rate to the questionnaire, and trusts used a combination of paper and telephone or both to get to that. The individual compliance is shown below. I would like to highlight Trust 5. They had started an audit just before we started this project, and they were accessing GP records to get information on patients who attended primary care. So they had a full data set, but they did not use the Public Health England questionnaire. I think it's also interesting, which I probably shouldn't say, that in that trust, they had a team of nurses who rang patients and did use the Public Health England questionnaire, but they wouldn't share that data with the junior doctors doing the project. So we were a bit stymied and had to use their existing method. So all hospitals reduced SSI. All hospitals reduced SSI, and you can see that shown here. There are some tremendous reductions in surgical site infection, except only one hospital did not. But you can see that they had an unusually low rate of surgical site infection in the first place. This gave us an overall reduction of almost 50%, which was our goal, which was 18% down to 9.5% in over 2,000 patients. And for those of you who use quality improvement methodology, This is an SPC chart, and you can see that there was a significant shift and a reduction in surgical site infection. And this led to a publication in the Journal of Hospital Infection. Now, could this bundle be adapted and used elsewhere? Well, 3 of the trusts started to use it after emergency laparotomy, which is emergency abdominal surgery. And again, we replicated the reduction in SSI. So in summary, for PreciSSIon, this was an adoption and spread project where we spread a bundle of care that had previously been shown to work to 7 hospitals, and we replicated those results by almost halving surgical site infection, which, if you add it up, is 115 patients prevented from developing an SSI, with an estimated cost saving of about £500,000 based on UK figures.
Thank you, Anne. So having had such a great success with PreciSSIon implementing this bundle in bowel surgery, we really wanted to see if we could spread the bundle and the work to other procedures and have the same effect. And so our attention moved towards caesarean section because this is one of the commonest procedures performed, and wound infection is not reported well because, again, it's not mandated nationally, but there is some evidence that actually wound infection following caesarean birth accounts for about 16% of all hospital-acquired infections, with an estimated cost of about £2,000 per infection. But also, as Anne had said, this has an enormous impact on patients, and particularly on mothers who've had a baby. So the same problems with pain and potentially length of stay, and that can have an enormous impact on them looking after their newborn baby. But it also has other impacts in terms of antibiotic requirements, maybe interfering with breastfeeding and affecting bonding with their newborn child, baby. And also, many of these mothers will have another caesarean in future pregnancies, and an infection caused in the initial caesarean may cause complications in the subsequent procedure. So it's got a bigger impact than potentially realised. And the other really important thing is that, as you can see in this graph, the rate of caesarean births in the UK and globally is significantly increasing. So this is a problem that's not going away, and has a significant impact on many mothers. We reviewed our data within our region and estimated that we have over 7,000 births, sort of caesarean births a year, and an SSI rate of around 16%, which is what has been estimated, means that over 1,000 of our women are having a wound infection. So this felt like a really worthwhile project to pursue. So again, as I said, this is not mandated for surgical site infection rates to be monitored routinely. One trust in our region was doing that because they have a large, fantastic infection control team that do continuous surveillance. But in the other units, there was no ongoing monthly surveillance. There were local audits in the spot audits in each of the trusts, and rates of around 15 to 19% were reported. So thereby, PreciSSIon 2 was born, so to speak, and our fantastic comms team came up with this lovely logo amended from PreciSSIon 1 with a nice big C and the baby there, which we all love. So PreciSSIon 2's aims then were very similar to PreciSSIon 1. We wanted to establish ongoing surgical site monitoring following caesarean births in all trusts across the region, and following that to reduce surgical site infection. And we aimed for a 30% reduction by March 24, and I'll come on to that in a bit. And these are the 6 trusts, the 6 acute units that were involved in the project. So we had a big challenge right from the beginning. because as with PreciSSIon, it was really important that we used reliable standard measures which captured surgical site infection rates up to 30 days after the procedure, as length of stay for mothers having a caesarean birth is usually only 1 or 2 days. So if we only used in-hospital data or readmission data, which a lot of the studies do, we would hugely underestimate the problem. So we used the same patient-reported outcome metrics at 30 days using the validated Public Health England questionnaire that Anne described before, with the same standard criteria. However, this was challenging, and we could not do what we did for colorectal due to the sheer volume of patients that we had. So in colorectal, it was possible to do this by paper and phone, one or the other or both, because there were 20 patients each month on average. But for caesarean births, there's over 100 mothers in most of our units each month. So it really wasn't possible for us to do this manually. So we needed a digital solution. And we collaborated with a company called Simplicity. And so the implementation of Simplicity in 5 of the trusts that weren't currently measuring their rates was funded by the Health Innovation West of England for 2 years. And the aim was that they would host an SSI dashboard that each of the trusts and us as the project team could view whenever we needed to. So Anne and I worked with the company to digitalise the National Public Health England questionnaire, and so that the responses to the questions would be automated to determine whether an SSI was present based on the criteria, the standard criteria. And so that template is there within the company that can be used now for anyone else that wants to use that. And then we had to establish a data extraction from each trust so that of all the women in each trust that had a caesarean birth, so that then this questionnaire could be sent either by email or by text after 30 days after the procedure. So as you can imagine, this required a huge amount of collaboration between multiple teams within the trust to get, in particular, information governance contracts signed, but also BRU and data analytics, but also between all of those trusts. Each trust really supported each other to unpick some of the problems. And we also collaborated with mothers to understand the complexities and the problems, and with associations such as the Maternal Voices Partnership. So a huge amount of collaboration again. And it was challenging. And I'm sure none of you will be really surprised that it did take time to establish all of this. So in terms of information governance, contracts and data extraction from each trust. So it took between 4 and 6 months to really get this established. Again, multiple engagement, but because of that, it resulted in a staggered implementation in each trust of the surgical site infection measurement, and thereby a staggered implementation of the improvement work as well. But we achieved surgical site infection surveillance in all the 5 units using the Simplicity system between November and February 2023. And so each trust has its own patient identifiable information that they can view whenever they want to. And the Health Innovation West of England project team can view all of the different rates in each trust, but that's anonymised data. And then following implementation of the surveillance, each trust ensured they had a minimum of 4 months baseline data before making any improvements. And this is just showing you a few of the sort of things that trusts can see. So they'll see their rate, that rate may be split by age and a few other things. And also they will have a list of the mothers that did have an SSI that they could interrogate further if they wanted to. There's also a feedback section, and so there's an awful lot of information in this database, and the Simplicity system can also use some AI technology to collate the quantitative feedback. And so we have just started to give this information to our patient experience midwives to see what we can do with it and feed that back. We were also able to demonstrate that this system was actually hugely cost effective. So it's a fantastic resource for us to have, like I say, readily to hand without any onerous data collection from the teams. But our wonderful team that are able to collect this manually did collate what that cost may be if we did spread that over to 5 trusts over 2 years in terms of the labour costs. So that would amount to about £163,000, whereas the electronic system that we've implemented cost £18,000 for the 5 hospitals over 2 years, so significant cost saving. So having established our first aim very reliably, we were now able to start some intervention work to try and reduce the rates. While that whole 4 to 6 months was going to establish SSI surveillance, we obviously were doing lots of planning in the background. So a huge amount of collaboration, again, with all of the teams, reviewing all of the evidence for interventions to reduce surgical site infections. And as I said before, also collaborating with mothers. And so we also co-produced in that time a wound information leaflet, as a lot of the feedback had been that mothers didn't really know how much information about wounds on leaving the hospital. We also collected baseline data of current interventions, as we did with PreciSSIon. So in particular, the interventions in the surgical site, so the WHO checklist that Anne spoke about earlier, to make sure that everyone was compliant with that before we implemented new changes. And then we agreed a bundle and we produced lots of resources, posters and such like, so that we were ready to start as soon as everyone had their baseline measures. And so this, again, is the bundle that was agreed with all of the leads, and all the measures were, or the interventions were, evidence-based and in particular affordable in the first instance. And actually, once we reviewed all the evidence, interestingly, the bundle became very similar to the original PreciSSIon bundle. So being 2% chlorhexidine, which actually all trusts were using already, but we added in 2 minutes drying time, which was recommended. Introduced antibacterial sutures for skin and sheath, and then 2 elements for some mothers, one being to repeat the antibiotics if the blood loss was more than 1.5 litres, because levels in the mother would be low, and to use a wound protector if the BMI was greater than 45. And the reason for this in caesarean birth was because it will provide a more even distribution of pressure rather than retractors on the skin to have access to deliver the baby, and thereby causing less trauma to the tissues. So each trust also then collected baseline measures with each of these bundle elements before implementing them. So as I said, because of that staggered implementation of the surgical site surveillance in each trust, there thereby was a staggered implementation of the bundle, which is shown here. So the bundle was implemented between March and August 2023. Again, we did very similar, if not exactly the same as PreciSSIon, in terms of the ongoing QI work, making sure that all teams understood QI methodology. We had our outcome measure as the surgical site infection surveillance we just described, and we collected ongoing monthly compliance with each of the bundle elements. We collected this for elective and emergency caesarean births on a simple form, again collected by the theatre teams, although some trusts have also established some electronic collection. The team ownership again became really important, particularly the theatre nurses who only put antibacterial sutures on the kit. Chlorhexidine, as I say, was in use before, but they are also empowered by, one of the teams was using a 2-minute egg timer, which was something that the theatre teams came up with, and that's now been spread to the other units as well. And it's been embedded into the WHO checklist as prompts. So lots of prompts to enable that we do the right thing. So how did we get on? It's a little bit more tricky because the trust did implement it in a staggered way. So what this shows is the baseline average surgical site infection rates before in each of the individual 5 trusts. And then that's on the left in the yellow, and then on the right is the average SSI rate after implementation of the precision bundle. You'll see that the baseline, if we combine the baseline rates in each trust, the average was 18%, but you can see that there's a big range between 13 and 25% across the trusts. After bundle implementation, there is if we combine those averages, there is a slight reduction to 15%. But what you can really see well is the reduction in variation. So most trusts are now between 12 and 15%, but there is one outlying trust which had a high-ish rate before, which has maintained that high rate. On analysis of further analysis, it does seem that this trust has got a higher rate of mothers with a high BMI, and that may explain that. So we have reduced slightly across the trusts, but not as much as we had anticipated. So this has been really interesting. So we have analysed all of the trusts' individual data, and this is SPCs for each individual trust, which, apologies, is a bit small. But essentially, it shows that 2 of the trusts have reduced rates, and the other 3 really haven't had much difference, which is why it also shows how important it is to have ongoing measurement, because initially it did look like we were all reducing to a certain extent, and then that's not been sustained. The one trust does look like the rates are going up, but in fact their response rates have also increased, so that may just be showing that. So we haven't achieved as much as we would have liked, and certainly it doesn't seem to have had the same effect as PreciSSIon for colorectal surgery. So the first thing, obviously, is, are we doing what we think we're doing? Are we implementing the bundle? As I said, it was one of the really important things that we did collect reliable bundle compliance. And actually, it does seem that we are very reliably delivering the bundle, with all trusts having over an 80% compliance. However, when we look at the bundle, only 2 elements two of the elements are only implemented in a small number of mothers, the antibiotics and the wound protector. And chlorhexidine was in use beforehand, although we are allowing it to dry. So I think what we have done is we have standardised care, and thereby that's shown by the reduced variation. But it does seem that the sutures, antimicrobial sutures, are maybe not having as much as an effect as they had in the colorectal surgery. But also, this is a very different wound to colorectal, which is an abdominal wound in the middle of the abdomen, whereas the wound following caesarean birth is a bikini line wound, essentially kind of in the groinish areas, so maybe more potential to be infected. And it's definitely a different cohort of patients who are more mobile a bit earlier, and like I say, a very, very different cohort of patients. The other thing is that as part of the standardisation of care for these mothers, the other thing that was made sure was standardised across the trusts was the dressing, in terms of the NICE recommendations are that a dressing is removed by 24 hours. And in a lot of the feedback that there is in the simplicity data, there's quite a bit of feedback from mothers about not having a dressing on the wound, which is something that we've also been thinking about. So the beauty of our project is that because we have this fantastic data set now for information on mothers having a surgical site infection following caesarean birth for over a year, and we have got feedback from over 6,000 mothers. We've got a massive amount of information. We've got nearly 70% response rate, which is fantastic, but it's also allowed us to have further analysis of these mothers and really understand what's going on and really look at the risk factors. We've also had a fantastic collaboration with Simplicity, the company that are providing the system, and they've adapted the dashboards quite frequently to our requests, but also as we now want to have more information, we've also worked with them to increase the data extraction, so we have more detailed data set, in particular looking at the risk factors. So we've added smoking, social deprivation, diabetes, whether it's elective or an emergency, and in particular we've added BMI. And that's been really interesting because we can now look at surgical site infection related to BMI. And so on this graph, you can see the orange line shows the surgical site infection rates for mothers with a BMI less than 35, and the green line for those above 35. And you can see that it's a massive risk factor, and rates are much, much higher in that group of patients. So our next step then, this is enabling us to now carry on with further work, and we've had a team agreement across all of the acute trusts to implement a negative pressure dressing for mothers with a BMI above 35. And this is a nice recommended intervention that we didn't do initially because we wanted to do the simple cost-effective measures first, and this is an expensive intervention. Also, the evidence for it is varied, but the majority of the evidence uses varied surgical site infection measures and are not using the 30-day measure, which, as we've described before, means that you may well underestimate the problem, or you will underestimate the problem. So because we have got a fantastic data set, we are going to be able to really analyse the effect of this on our mothers. And so we are planning a 6-month trial to really look at what happens. And because of the fantastic data that we've got, that's been easier to get over the line in each trust in terms of the cost of that dressing, and we will also be able to add to the global evidence of what is an expensive intervention. So it's a really exciting phase for us. We're also collecting, as with everything, compliance with that intervention on mothers with a BMI of 35, but we've also added to the questionnaire that mothers get some information or some questions about the dressing. So we will know the recommendation is that the dressing is kept on for 5 to 7 days, and we're collecting that data. So we'll know whether it has been used as it should be. So this will be really, really good evidence to see whether this is effective, and it's quite exciting. So because of needing to get approval and procurement, as well as some training in the dressing and making sure we're collecting baseline measures, because as part of this information gathering, it's become apparent that some of the trusts are also already using this, but in a non-standardised way. So we will standardise that and really see the impact. So the plan is to start that from August. And again, as part of gathering lots of information and investigating everything, we have found some evidence that changing the gloves after delivery of the placenta does have some effect on surgical site infection. So we've implemented that from June. And again, with our fantastic data set, we'll be able to see what impact that has, and that's for all mothers. So it's a really exciting time for us. We're entering phase 2. So watch this space and see what happens. So in summary then, for PreciSSIon, as Anne so fantastically described, we nearly halved surgical site infection across the region, which was an amazing success story. And with PreciSSIon, we've spread that work to caesarean births. We've established reliable surgical site surveillance across the west of England now for over a year, have a fantastic data set and information on over 6,000 mothers. And That's enabled us to really understand the problem and really see the effect of the interventions, and led us to a second phase of work, in particular looking at mothers with a BMI over 35. We were also delighted to be awarded a bronze award for the most impactful partnership in prevention of healthcare for our work with Simplicity at the HSJ Awards in March 2024, which was really exciting. And this is our journey. So we're on a journey. A bit busy this, but essentially says what we've done. We're entering phase 2. So we have achieved a small reduction in surgical site infection following caesarean birth with our initial interventions. But in particular, we've established a massive amount of information to really understand the risk factors. And we're just entering our second phase with 2 further interventions, using our fantastic data set to really reliably identify the impact of those, and particularly, as I say, for those mothers with a high BMI. So it's an exciting kind of time, really, and keep an eye out for how we're doing. So thank you for listening. Do get in touch with us if you want any further information, and we're happy to take any questions.
Excellent. Thank you very much, ladies. We've got quite a few questions coming in, so I'll run through them as they came in while you were talking. We got a lady called Gillian McCafferty who's been in touch. Doesn't say where she's from, but she wants to know what percentage of the patients had the complete bundle put in place.
Ooh, great question.
So we really worked on having about 80. If we get to a compliance of 80% with the full bundle, then that was our aim. And I haven't got those figures to hand, but I think in most of the trusts we were close to that. Certainly in terms of the PreciSSIon 2. It's over 80% of full bundle, because remember, 2 of the bundle elements are only in a small proportion of patients. So it's more like over 90% for the 2 core bundles. And then the others have been a little bit intermittent, but have improved. So pretty much, in fact, in terms of the wound protector, we have decreased the criteria for that. So it started with a BMI above 45, but there were so few patients in the majority of trusts with that, we have decreased it to a BMI of 40, and that was mainly also on what we found out was that actually people were using it in BMIs that were lower because they wanted to use it. So it's probably used more frequently than just in the criteria that we have.
Yeah, I can't give you a figure for that. We did look at it for PreciSSIon 1. It's lower than 70%. That's a cracker of a question, first off. But the benefit of our data is that we will be able to tell you. But it's only, you're right, it's only about 70% in total for all the bundle elements.
Well, we've got another question here, which again probably put you on the spot. Mary and Marla, can you confirm, did all the patients get antibiotics after 4 hours?
Well, we showed the compliance with that. No, it was about 80%.
All right. Okay, then. And the compliance with the WHO bundle and colorectal study, what was the compliance with that?
Yeah, so we wanted everyone to get to above 90%. Now, I was reflecting on that, and the reason we ended up doing this is the South West had a history of quality improvement. So a lot of us were involved in the Safer Patient Initiative back in 2009. And then Sir Ian Carruthers set up a patient safety collaborative across the South West a little bit after that. So we all had to work on the WHO checklists. So I was thinking, if I say it's 90%, you're not going to believe me. But it was because we'd actually been working on it for 10 years across the region.
We had already implemented that piece of work, so really it was a check that everybody had sustained that work, really. So it wasn't new work, I think, was it? And that was why it was a bit
most
easier
hospitals
for us.
were recording it already. So temperature greater than 36 in recovery and glucose control for known diabetics was routinely being measured. So it was 90% or above.
Yeah.
Brilliant. So Joseph, Amelia's been on. How was the Simplicity software funded across all 5 trusts? Cost savings usually being primary emergency care, not in the hospital itself. How was this balanced, and was the ICS involved in this from a financial perspective?
So the Health Innovation West of England, who are supporting this project, funded it because they're the support for the project. So they funded it in the 5 trusts to enable the project to happen. That funding will finish. We have actually just extended it with this second phase of our project. So there's a little bit more resource come from the Health Innovation West of England. But we're now starting to ask the trusts to have conversations with their own teams around from next year, putting this into their business case if they want to maintain it in their own trusts. But the beauty of that is that they'll already have the evidence of what it's done and what it can do. And it's also not that much money for each trust. So as I say, it was £18,000 for 2 years in 5 trusts, and that included the setup costs. So I think, again, it's one of the real advantages of engaging with your health innovation network, because this is the sort of thing that they can fund, again, to demonstrate how effective something could be if you can't get that funding upfront from your own trust.
Yeah, I'd also like to mention that the company mainly set up to do PROMs for cancer patients and after joint replacement. So it can be used for many other things. And in my own hospital, it's being used for shared decision making and measuring quality of consent. So it wouldn't be easy. It may not be easy just to get it in for one thing. But actually, it's a very versatile thing that, if it fitted with your trust digital strategy, that you could get that information for lots of different things using the system. And I suppose it's also important to say there are other systems available, so it's not just this one.
Right. Zara McKinstry from NHS Buckinghamshire. Was this implemented for emergency C-sections, or was it elective?
It was both.
Both.
Simple enough answer, wasn't it? Did you use chlorhexidine 2% alone, or did you use with alcohol? That's from Claire Robertson.
Yeah, it's alcoholic, and that's one of the reasons why it has to dry. So it should be allowed to dry anyway because of the risk of setting the patient on fire, but that's how it works for SSI. So it was alcoholic. And I'm going to tell you an anecdote now. There was one surgeon who refused to use it in one hospital, and we thought he was just being difficult. And actually, it turned out he'd actually had an incident where he'd set it alight, which was the reason why he was against it. So there were lots of good reasons for the 2 minutes to let it dry.
Wow. There's somebody who's not left the name, but we'll ask the question anyway. Which organisms were most prevalent?
So we didn't look at that in colorectal, because the whole point of patient-reported outcomes is not is patient-reported and what's clinically happening. Now, there is a question in the questionnaire that says, was a sample taken from your wound? Actually, that wasn't filled. That didn't happen very much of the time. It was a small proportion, and therefore, so first of all, most patients don't have wound swabs taken. In my own hospital, it's the usual mixed organisms, you know, E. coli, anaerobes, but that's not something we looked at. And I don't know the answer for cesarean.
No, again, probably even less have have swabs taken for cesarean, but it is that question. The question is there, and again, we have got all of that information in the database, so we could look at that, but we haven't as yet.
Okay. Another question from Joseph. Did you look at the antibiotic choices in the guidelines between different trusts, or were they all the same?
Yeah, we did.
We did.
We asked them all. They were all very similar. However, when it came to repeat dosing with the 1.5 litres of blood loss, so for colorectal, they were one of two things. They were usually amoxicillin, gentamicin, and metronidazole. There was one hospital that was using Augmentin. For cesarean, it was usually Caf and Met, wasn't it, Leslie? I think. But there was one hospital that was really interesting in terms of the repeat dosing. So that's where there was variability. There was one hospital that wanted to give a half dose of a second dose, which was a bit of an outlier. And we did get microbiologists to talk to each other about that one.
Right.
Yeah.
Okay, Angel, you've been on. Are these infection rates solely based on the interpretation of self-reporting data on Simplicity?
Yes, they are for cesarean. For colorectal, well, yeah, they are for cesarean. Yes. So if the question is around in-hospital surveillance, there was for colorectal, there was one hospital where they were using in-hospital surveillance too. However, it's important to remember that the questionnaire says, did the infection arise in hospital? And also asks, if you did get readmitted to hospital, which hospital you go to. So the questionnaire is designed to capture in-hospital SSI as well.
I think the other thing to say is as well, just we said this in the presentation, but this is the standard Public Health England questionnaire, and the criteria that then are based sort of the criteria used to define whether or not a wound infection is present is standardized from that questionnaire, which is the National Validated Questionnaire. And it does include questions about obviously antibiotic use, because that's one of the two of the criteria, or it's within two of the criteria, but also whether or not they were seen by a healthcare professional. And the majority of people were seen by a healthcare professional. So much as it is patient reported, the majority of these people have also been reviewed by a healthcare professional. But the main thing is that it's a standardized questionnaire before and afterwards. The same.
I mean, I have looked very carefully at the colorectal data in my own hospital. You can see that I reviewed 1,300 patients. Most of the in-hospital SSIs are reported on the patient reported. However, there is an inaccuracy sometimes in using patient reported, because I know there were a few patients where they said they didn't have an SSI, and I knew they did. And I knew they did. But you sort of have to have a method and stick with it.
As long as it's consistent, I think that's important. Yeah.
Well, yeah. Andrew Garner has been on. Have you looked at PHMB as an alternative to chlorhexidine for intraoperative washout, or PHMB wound gel for surgical sites to reduce potential of both superficial and deep infection?
Oh, the answer is no. That is something we don't know much about.
Right.
All of our bundle elements recommended by NICE and the WHO. Wound irrigation isn't in there. Betadine in the wound has some weak evidence. So I have to say, for colorectal now, I use that, but it's weak evidence. I don't know about that, so maybe you need to tell us about that after that. You should be giving the webinar.
Send us some information. Yeah.
Well, we know Andrew very well, so we'll put him in touch with you, and he can talk to you about that.
Yeah.
So yeah, Lillian Chuera, another friend of ours. Your
hi,
thoughts?
Lillian.
We know Lillian. Yeah.
Your thoughts regarding removing a CS dressing within 24 hours, given a location of CS wounds, i.e., close to the groin, not so clean parts of the body, etc. Does this practice potentially increase SSI risk?
Well, it's been interesting, isn't it? Because again, that's what NICE recommend, that the dressing is removed between 6 and 24 hours. And so again, we wanted to make sure everyone was doing the same thing. So that is something that we standardized as part of the initial work. But as I said, you know, a lot of the feedback, or there is a lot of feedback in the questionnaires from mothers saying, oh, you know, I didn't have a dressing on, I feel I should have had a dressing on, and you know, that kind of thing. So, and again, it's always something that we thought, well, but it's NICE recommended, that's what we should do. So I don't think we can answer whether it increases the risk of infection, but we certainly don't think that it's stopping, you know, it's having any effect on preventing it. And so, like I say, now we are moving to putting a negative pressure dressing on mothers with a high BMI, and that'll be our next phase. Obviously, we need to see what happens, because we're also quite mindful about the fact that we're not doing anything for the other mothers in terms of a dressing, so there may be another phase to come, but we just want to do kind of one thing at a time. And there is some work on other dressings, but I guess one of the issues with all of this is the measures, because a lot of the published evidence uses not particularly standardized measures, and it is all on either readmissions or something that may be documented in notes, but that's not really standardized, which is why we are really insistent on this 30-day standardized validated questionnaire from Public Health England. And it may not be perfect, but it's what's validated, and it is consistent before and afterwards, and is 30-day. And we think it's really important to get the 30-day data, because without that, we're definitely underestimating it.
So can I say something about dressing? So Lillian, you probably know, I was part of the Bluebell study, which looked at dressings versus no dressings. It's only a feasibility study, but there's never been any evidence that dressings reduce surgical site infection. But it's interesting what you say about taking it off, because it does seem a bit weird, and I'm not really familiar with the evidence around that. But the other thing that's interesting to me is I've tried to reduce surgical site infection after urology and vascular. Urology, brilliant, reduced it, abdominal wounds. Vascular, groin, it's not made any difference, the bundle so far. So I think there is something about wounds that are transverse, that live in creases. And I think you could be right, Lillian. I think maybe in that situation where you get sweaty, moist, and exudate can collect, maybe dressings are required in those situations. But we can't, Leslie and I can't answer that.
We took a long time not to answer it, Anne.
Yeah.
Another one here. Did you use chlorhexidine in an applicator? And a secondary to that, what type of dressings were used?
So chlorhexidine was used in whatever way the trust wanted. So I don't know what they used, but most, so at the time, I don't know if everyone can cast their mind back, there was an alert. You weren't meant to use the bottles of chlorhexidine because they weren't licensed for skin prep. But we did do a piece of work with the pharmacists to make sure, and the ChloroPrep, which is the alternative, was very expensive. So we did do a piece of work to make sure that most hospitals had the governance in place to use the liquid. And I think most people use that because it's cheaper. And there have been, we did not have an allergy or an incident with using that across, hundreds of patients. In terms of dressing, we did not standardize that for the colorectal project. People were allowed to use any dry dressing, and in colorectal, sometimes if there's a stoma, people use glue. So, you could be right, there could be a confounder there, but most surgeons use glue if there's a stoma and a dressing if there isn't. But we didn't tell them what dressing. It was just a standard dry dressing and not a fancy one that costs money, basically.
Yeah, and the same for cesarean. Yeah. Although actually some trusts were using some specialised dressings, but again, slightly ad hoc at surgeon discretion. And to be honest, in our analysis more recently, it's kind of come to light that I think some trusts are using them more than we thought initially, which is why it's really important that we get baseline measures for what dressings are being used before we implement that next step.
Right, well, we're rapidly running out of time, but I've got one more question here, and this is probably to Anne, because you are a surgeon, and it's from an unknown user, and you'll probably understand why when I give you the question. How do you address
Why
surgeons?
are all surgeons so difficult?
Yeah, well, basically, how do you address surgeons saying there isn't an issue and discounting patient-reported SSI? They are finding it really challenging.
Oh God, I know. I've lived through this. So I remember when I tried to do this, they'd go, well, first of all, people say, I don't have a problem. And so the first thing you can say is, show me your data. Where's your data then? Because here's my data, you know, and there's that fabulous quote, isn't there, from Deming, you know, without data, you're just another person with an opinion. So the fact is that I think data trumps no data every time. And what I used to say was, look, yeah, you're right. Sometimes this may be a hematoma. It may not be a true infection. However, this questionnaire has been validated and standardized to try and pick up surgical site infection. But you're right. You're right. They may not all be infections. However, 20% of your patients are having a wound problem. And look at it. They're going to they're seeing a health professional. They're getting antibiotics. They're having dressings. So in the beginning, I said, I don't really care whether it's an infection or not, but people look at this description here. Your patients are having the wounds edge is separating open. There's pus coming out and it's red and sore. So I'm not going to argue that point with you. So, so that's the first thing. Then surgeons react very well to competition. So if you can show them data that shows that they're worse than someone else, they react usually very well to that. Once you start measuring SSI, if you have enough data, you can show variability between surgeons. Now, you have to be careful with that because it may be due to their case mix. So some people might do low-risk surgery, some people may do different surgery. But the other thing you can do, so this is what I did for urology, you know, oh, look, guys, I don't know what you do. I think some of you do really difficult operations, but oh, look, someone's got an SSI rate that's 10 times the other. Here's the data. Have a look at it. So if you show people data that shows they're worse than others, that also helps. In terms of asking them to do things differently, pointing out that this is evidence-based and this should be the standard of care, is useful. And also surgeons will also want the fancy toy. So they'll go to a conference and someone will tell them to use a negative pressure dressing, but actually, and probably give them a pen. But, you know, it's about the basic stuff first. So I trying to get surgeons to address the basics is also really hard. And just go, look, these are evidence-based things and you're not doing them. So those are my tips, but I could talk to you about this for a very long time separately. That's
also where the theatre teams come into their own, don't they? In that they make it more difficult for them to have what's not the standardised kind of kit.
Oh, yes.
You know, so it makes it, or they prompt them and they go, oh, okay. So the theatre teams become really, really important in kind of almost enforcing that the bundle gets delivered.
Except to do that, you need a leader who gets team agreement that that's what they're going to do, and then you make it more difficult for them not to do it. So if they have to ask for, so you can make a rule that you're going to be offered an antibacterial suture unless you specifically ask otherwise, and then if they haven't asked otherwise, they'll go, oh, all right then. But also, if there's I'm going to say one more thing for urology. They did have to change their practice because they wanted to use Vicryl Rapide, which is a stitch that dissolves, and they were doing an interrupted stitch and they didn't want to do a subcuticular stitch. So it's more difficult where they have to change practice. If they can do the same, it's easier. But I can talk about that for a long time.
Make it easy to do the right thing. That's the tip.
I was just going to say we can talk about this all day. We could do another hour on this, but unfortunately we've run out of time. Thanks to our panelists today, Anne and Leslie. Excellent presentations. Hopefully you guys have taken something from the webinar. Any questions that we've not answered, and there are a few, they will be forwarded to the speakers. They'll endeavour to answer them by email. If you'd like to watch the webinar again at your leisure, it will be available on the Nolex website from Friday the 7th of June. All you've got to do is go to www.nolex.com www.nolex.co.uk and click on the webinar banner and you'll be able to watch it. Thanks again, ladies, and thank you for watching. Enjoy the rest of your day and bye for now. Bye-bye.
Thanks for coming.
Yeah, thanks for coming.
Blimey.
Bye.
Bye.